Hello, everybody. I'm going to admit the other participants. We have several colleagues I am very happy to see. This probably is a result of our connection with Wonka. Thank you, Dr. Ngan, for creating this opportunity for us.
It's a pleasure.
Yeah, I think everybody is or waiting in the waiting room with us. Now, to start our meeting, our fourth intergenerational meeting, I would like to say a few things, and I will please mute your connections. I would request you all. Then I will forward the floor to our moderators. Today, Ramin Aprao and Idil Kına are our main moderators. They are our student moderators. And we will have a discussion on integrating psychiatry into primary care, together with colleagues from Wonka, the main one being the past president of the Wonka Europe, Professor Mehmet Ungan. He will be with us. But first, I see Rachel Jenkins is among us. There are could you please mute all the others? If anybody has anything to say, we would prefer them to write. Okay, let me hand it over to Ramin, then you can share it with Idil.
Okay, good day, everyone. I hope you're all having a great day wherever you are and at whatever time it is for you. It's 5 p.m. here for me in Malaysia. So yeah, I just got back from the clinic anyway. So yeah, welcome to our fourth intergenerational meeting where we have, as was beautifully outlined by Professor Koskun, it's a meeting between our senior educators as well as and our students, right? So to kick things off, who shall we invite first, Idil?
I believe Dr. Sartorius isn't here with us right now, so we can actually start with Dr. Jenkins. Hello, Dr. Jenkins. Are you here? Yeah. Hi. You're muted.
Hi there. Yeah, I'm hearing you. Thank you very much for asking me. I think the first thing to say is I think this is the most important topic. If you have to choose any priority, for me, this is it, really. Yeah. And the reasons are clear. It's because we know from our epidemiology that mental disorders are so common, something like 1 in 6 of the general population. And there's no way that you can ever have enough mental health specialists to see everybody. So it needs to be not just a family community business, but also primary care business. It needs to be core business for them. And this is our big problem, because at the moment there's a lot of attitudinal stuff around, particularly in the UK at the moment, I have to say, that it's not core business for primary care. That they feel they're doctors from the neck down, as it were, and that anything to do with mental health should be referred. And this is disastrous, really. So that's the first reason, is the epidemiology. The second reason also relates to that. We know from our studies that mental disorders are highly associated with physical disorders. The comorbidity is very great. And they have social causes and social consequences. And so primary care, well, we all need to be, but particularly primary care needs to be biopsychosocial. But that mix makes it imperative, I think, that you shouldn't carve it up too quickly to go to a mental health person, right? And this is problematic in the UK just now, because some years ago they introduced a system of young psychologists taking referrals direct from primary care. And what it's meant is that comorbidity has got missed and neglected, and all those social causes and consequences haven't been well handled either. So we need every consultation, I think, to be biopsychosocial in its approach to assessment, diagnosis, and management. But that obviously needs training appropriately. So we need to address the basic training of all our medical students, nurses, and so on, so that they have a good skills and competences in this. And then the vocational training, in the UK, we have vocational training for GPs afterwards. But of course, in many parts of the world, that's not the case. People are thrown in at the deep end and have to cope. And so often what you find, say in places like Africa, is that primary care staff are not bad at treating psychosis. It's visible to them, they identify it. And if they have the medicines, they can make a reasonable start. I mean, it can often be improved, but if they have nowhere to refer the person, they can still have quite a good go at treating. But what you do find in such busy clinics is that depression, anxiety tend to be completely missed, not recognized, and are the cause of repeat consultations, many repeat consultations. This happens all over the world, of course, when it's missed. In one of the formative studies I did as a young researcher with Anthony Mann in a rural area in the UK, we followed up a group of 100 people with depression and anxiety over 10 years. And we found that even though they might have got better once, they relapse later on, quite often. And over the 10 years, many of them had consulted over 12 times a year during that period. Now, that's a huge burden on the health service, coming in once a month or even more often to see your GP, when in fact, if they'd been properly sorted out to begin with, that wouldn't have happened. So you often find that primary care staff will say, we're too busy to do this. It's all very well, but it's simply not reasonable because we're too busy. But one of the reasons they're too busy is because they've got all these repeat consultants who keep coming back because they're coming with a physical symptom, but actually there's an underlying psychological disorder. So when you teach people who are working in primary care, they all recognize the person who comes in saying, I've got a headache and I feel unwell, doctor, and I think I've got malaria. Or in the UK, it's I've got a headache, I feel unwell, and I think I've got flu, doctor. And so they're wanting a physical treatment, but what they're needing is a decent biopsychosocial assessment. So sometimes they do have the physical disorder, sometimes they have both, but often they have the underlying psychological condition.
So I just wanted to get back to something you said at the very beginning. I think it's very important to underline what you're basically saying is that primary care is not simply a point of referral for further mental health services. It's the place where we can actually effectively provide mental health care. Is that?
Yeah. Yes.
Yeah.
Yeah.
And when it's done like that, it can actually further reduce the burden on the healthcare systems rather than just like acting as a continuous referral center.
Precisely. It shouldn't just be a signpost. Yeah. And often, you know, we talk about task shifting, but I've always got annoyed with that phrase because I think it's most unfair, because I think the tasks have always been there in primary care. And if you go into a primary care clinic, say in Africa, you will find them dealing with people with psychosis. The specialist services are too scarce for everybody with psychosis to be able to go to an outpatient clinic. So the tasks have always been there. The people with depression, anxiety have always been in primary care. The issue is to support primary care to be able to deal with them. And so I think it means the specialist services need to think long and hard about how best they can support their local primary care teams, how to get to know them, support them, listen to their needs, work out a very good interface between primary and secondary care. That obviously means attention to the medicine supply, the health information systems, which are very important, usually don't address mental health properly at all, which makes it very difficult for planning purposes. And then obviously teach as much of the basic psychological skills as we can. But just good communication skills, respect and understanding goes a very long way before you have to get into more complex skills.
That's also very interesting because I think it's directly related about the second part of like the topic we're discussing today, which is the psychiatry in medical education and the skills that we can get as medical providers, whether we are communicating with our patients or we are communicating among colleagues, addressing the psychiatric or mental health needs of our patients. Something I wanted to ask is, you're a very prominent epidemiologist in your field, and your research focuses a lot on the healthcare mental health care services in low and middle income countries. So how does the disparities between higher income countries and low and middle income countries, especially disparities in healthcare accessibility, primary care structures, healthcare systems, or access, like the amount of specialists there are, how does this impact this integration of psychiatry in primary care? Like, do we see in low and middle income countries more improvement when we invest in primary care, or like is it easier for primary care to be utilized this way in higher income countries?
I'm not quite sure I quite understood the last bit of that, but anyway, in a clinic in Africa, for example, a primary care clinic will have a population probably of about 10,000 people to look after. And to do that, that clinic might have one nurse or two nurses and possibly one clinical officer. Now, the clinical officer will be like your barefoot doctor with 3-year training instead of 6-year training. But they won't always have a clinical officer. And in those situations, the nurses will prescribe, and they've been trained to prescribe. They don't actually always have a government mandate to prescribe, but everybody knows they prescribe, and they're taught how to do it when they're students. So it's not a disaster that they prescribe. In the UK, in comparison, our GPs, we have one GP to every 1,700 people, all right? So, and that's a GP with a 6-year training, and often a vocational training of 3 years on top of that. And they may have some nurses to help as well. So the disparity is huge. But after this, I can email around some tables I've done about some information I've got, which I haven't got at my fingertips now, about numbers of doctors per head of population. But the disparity is enormous, absolutely enormous. Now, in, again, somewhere like Africa, for 250,000 population, one district, you may have one psychiatric nurse running outpatient clinics. So you can see that, therefore, most people with psychosis cannot be sent to that psychiatric nurse. It's not possible. So it has to be done in primary care, and they do it, as I say. What's done can be improved, can be supported with more training, but they do it. But what's missed is the depression and anxiety, and also the children's disorders tend to be missed as well. So ADHD, autism, emotional disorders tend to be missed. So those are the things one can teach and support about. Now, again, in Africa, you'll find a psychiatrist probably at the regional level, somewhere between 1 and 5 million population. But again, you know, the proportion of difficult cases that they can see is very small. And they have lots of intersectoral work to do, teaching to do, etc. as well. So it's quite a challenge to make sure that primary care is well supported. But I think that's the task.
Rachel, if you don't mind, may I ask Ramin maybe to give the floor to another colleague. Thank you very much for your interventions.
All right. Thank you so much, Professor Jenkins. I think we have many wonderful speakers here today, and it's great to have started off with you. I think I'd just like to touch up a bit on what you mentioned about the biopsychosocial model. I think you've mentioned it during our last intergenerational meeting as well, and it's very curious. Something that I found that I could relate to was that my seniors who had just sat for their recent their exit exam, their professional exam, I overheard them complaining to me. Complaining to each other about their theory paper, which consisted of one psychiatry question, and it was about a question of a patient with illness anxiety, and they asked this same kind of thing, like, why do doctors need to learn psychiatry? Why do we need to have this this thing in our education? And I think what you mentioned is pretty spot on, that it's not always that a psychiatrist will actually deal with patients with psychiatric disorders, because there is no health without mental health. So with that, I think we can move on to our next speaker. I would like to invite Professor Norman Sartorius to maybe share some of his thoughts.
Thank you very much. My first question is really, why are so many people hiding their face? What is this? Why are we, the teachers, have to look and smile and they cannot go and have a cup of coffee while everybody else is hiding behind the black float? It's maybe it's an interesting psychological problems. But I think that maybe Professor Rustun or Professor Choshkun, I think, would be at some stage should put a rule that people should show their face when they are participating in a meeting. Or alternatively, they can go and do other things if they want. But while they are here, I very much like to see them. Maybe we'll recognize them. Maybe we'll see them again somewhere. It's nice to see people's faces. Now, my point about the is that it is extremely difficult to transfer. We have done this, all of us have made this mistake, to transfer the knowledge from one country to another, as if it was just doable like this. So we say, we know that in the United Kingdom, 19 or 18 out of all 20 people with mental disorder will first see a general practitioner, and only 2 will go directly to a psychiatrist. And therefore, this is like that in other countries, but it isn't. I think that general practitioners in different countries have different roles, different respect, different income, different position in society. And to just simply transfer things from one place to another is very often dangerous and leads to failure of many of the programs which we have done, because we have said, well, since it works in country A, country B is just as poor or just as rich, so why don't we move with the same principle into country B? And I think that that is not doable. Yeah. But extremely important. Sorry. No. Sorry. So I think it's of great importance to really say there are countries which this, that, the other thing have happened. So let us explore in my country, with my conditions, with the this, that, and the other, the conditions in which you have, what is the best solution, the best use of resources which I have. And very often we'll find that this is a very different proposition from anywhere else. A recent example, I think, to me was after a long-standing controversy between people who were, some of them saying that the traditional healers and should be allowed to treat mentally ill people, and then other people have said they should not be allowed, and then there was a campaign against the traditional healers, and then the others were saying, no, this is part of our culture, and therefore they must be allowed to do their work. There is a recent model which I think which was quite nice, which is a traditional healer in Nigeria who regularly invites a nurse from the nearby health service to come when there is an excited patient to help, if necessary, with medication. They're not hating each other, they're just trying to find a way to live together. Well, that system in this particular setting seems to be working. Whether it would work next door in Ghana, I have no idea, but it's worth exploring. And I think that we should be less certain about giving advice on how best to organize service and be more humble in our way of thinking. We know now, the knowledge is there. We know how to treat particular mentally disorders. We know how long it takes. We know what the difficulties are. And we should probably have these elements and put them together in a manner that will be corresponding to the local situation. One definitely forgotten piece of work that is forgotten in most countries of the world is to think about carers. We know that people who look after, who have a family, for example, a member of the family falls sick with a mental disorder, suddenly all of the other members of the family have an increase in the number of consultations for physical illness in the period that follows. A variety of other problems emerge. And until now, in most countries of the world, the attention and support to carers in the long run has been minimal. The carers, for example, of people who live and look after a person with dementia or with schizophrenia for many years, are living in a condition which very often leads to their burnout, leads to problems, leads to rejection of the patient, leads to a variety of other consequences. So my feeling is that definitely one area in which we should put much more work is to think of how we can help the carers of people with mental illness. Not only educate them, but much more to help them concretely. Educate them is an interesting word, because I would like to see for medical students worldwide to have carers come and teach them about being with a mentally ill person. What does it mean to be with a person 24 hours a day? If he has schizophrenia or is a demented person who goes in all directions and could fall off or put fire in the house or whichever else he might do by accident. And we have not done sufficiently to support them, to think of ways of improve their life, to improve their conditions, to teach them perhaps, but also to be willing to learn from them about ways of looking after mentally ill people. I've seen only a few places in which carers are regularly invited to the course of psychiatry for medical students to teach about ways of living with a mentally ill person. And when it does, it's usually a surprise. Sometimes people go further. In Paris, for example, some time ago, Dr. Herzlich was making it necessary for people, medical students, to spend one day and one night in the home of a person with schizophrenia, to see what it is like to sleep next to a person with schizophrenia. Because many of them have never seen a person in schizophrenia except in a department of psychiatry, where this person was come and where in many ways he's not typical in any way anymore of the ordinary person who suffers from the disease. So she has requested that students spend a day, and they came back, all of them, I've read the reports, they came back changed. Some of them had the experience anyway, because they themselves had maybe a parent or a family member who was mentally ill at home, but many of them did not. And before we start speaking of community care and of the role of general practitioners, etc., we should learn a little bit more about carers and families. There is only one paper that I've ever read in which it is requested that we should, before we discharge a person into the community, assess in a standardized way the capacity of the family to accept him or her, to be looked after by him or her in the community. In most other instances, the role of the doctor, of the psychiatrist, is to prescribe something, to give some advice, and off he goes. And when we discharge them, it's not that we have invited the parents for 2 weeks training before we can discharge a person to their home. No, we just discharge them like that. So those are the 3 points I'd like you to maybe discuss further. One is the role of carers and ways of helping carers. Number 2 is building services in keeping in mind the local conditions and building services to fit, to be harmonious with the local conditions. And thirdly, to think of ways in which one can establish an alliance with all the different people who might be helping people with mental disorders, from traditional healers to the local social workers, to all other services that exist. There are many services in the community which could be tapped if we only took the trouble to explore who the hell lives in this community and who are these people and what are the addresses that we could have. We have done in Geneva here a booklet with addresses of what all people who have trouble, what all they could need with telephone numbers and with addresses. And we gave this booklet to several people who discovered that for most of the things, they had no idea about the existence of these services, their role, the way to reach them, or anything else. So I think I'll stop here and leave you to react to that.
Yeah, thank you so much, Professor Sartorius. Yeah, I think that's a very interesting experience. I'm wondering if I could suggest this to my faculty and allow us to, experience, some of the things that you've mentioned, like, for example, seeing how patients with schizophrenia are and so on in their homes. And I think it touches back on a subject that we have, spoken on before in our second intergenerational meeting, which is about stigma itself. I think it would touch about, addressing medical student stigma towards psychiatric illnesses. Dr. Ungan, you have your hand raised. Would you like to share some thoughts?
You talk to me? Would you like me to speak?
Thank you for giving me the word. I think I have seen many good faces. First of all, I would like to thank you for inviting the general practitioners and the family doctors across Europe. And I am very happy to see very well-known names here. And also I appreciate my colleagues who are currently watching us. And this is very important to see all the young colleagues are very much interested in, and those experienced and seniors are trying to touch and to have a connection in between, which is extremely good initiation. Then I think it should be supported and should be continued in that way. I just had some notes in front of me. Of course, I can talk a lot of things related with the psychiatry integration of it in general practice. First of all, I have to tell you that I think we should not only think about the rural in Africa and such kind of places, but also we have to be very careful about very much developed, so-called very much developed countries in Europe also. So we have faced with a very high burden of the non-communicable diseases in Europe, especially those countries who are really crowded and living in crowded cities. It's a kind of, puzzle for us also for the GPs, because we are suffering in the rural parts of the Europe, and also we are suffering in the very crowded metropolitan cities of the Europe. And what is at the end is same for the patients we are taking care of. It's not easy to access the psychiatric services. It's not easy to access the consultation, not a proper two ways of communication with the GP and the consultant. So those are all the problems which we really face in practice. But what I would tell you is also there are some needs. I think Rachel and maybe Norman were mentioning about the professions in primary care who should be considered as the resources in family medicine. So one of those resources in family medicine and general practice. So this is correct. We have to share the roles and we have to really work together in primary care, whatever the topic is, either psychiatry or cardiovascular diseases or diabetes. Those are all really high burden diseases in the populations. So we cannot handle it alone, for sure. But what we should be very careful is, as general practitioners, we have to be working on with our partners about the professional borders. So if we want to be carefully giving a hand to the population which we care, in the policy level and on the level of the professional associations, we have to be really careful about the professional borders, which I know that for example, in cancer care, the same discussions are continuing. First of all, I would agree on what Rashad told us. The biopsychosocial approach is at the heart of our profession. I can tell you that's why the family medicine and general practice specialization is here in this world. If there is any holistic approach in the general practice, it is usually successful, but it's not enough. The general practitioners and family doctors are not making the rocket science. It's not an edge science, but it is a huge amount of work in the primary care trying to heal the people, to take the people and to know the people. In the UK and some other countries, which they have a very firm and very competent general practice, there are registered lists of the doctors. And that means that they know and they have a very long relation with a patient. This is an advantage for the primary care physician who knows a patient for a long time. So it's not only about spending 10 minutes, 15 minutes, 20 minutes with a patient or making exactly the application of the psychiatric rules in the practice, but also knowing that patient for many years and using the advantage of knowing the social environment of that patient, occupation of that patient, and the family structure of that patient. So those are all indicators for us. For example, if our long-term patient is changing the behavior or the question type changed, or even when he walks or she walks in the room in a different style with a different face, we really suspect immediately because we know it beforehand. So this is the advantage of the time advantage and the advantage of the primary care service, especially. So what I would say is, it's very important that to know that for the general practitioners and for the students, especially, I am telling about it, 5 of first 10 diseases that cause disability in the world, 5 of 10, depression, schizophrenia, bipolar diseases, problems related to alcohol use, obsessive compulsive disorders, and 5 of them are psychiatric disorders, if you see. I mean, we are taking care of the cholesterols, and the other non-communicable diseases, but the first 10, and among first 10, 5 of them are in the psychiatry area. So it is clear that an interdisciplinary cooperation and collaboration an integrative model is required to overcome the health problems in this 10, first 10 non-communicable diseases, including also the psychiatric conditions. So what I would add is, early diagnosis and the history of the patient all are related, and knowing each other for a long time is related. Primary care team is a key for integration of these primary healthcare services and psychiatry and the other non-communicable diseases. But also we have to be very careful. To my opinion, now in the conditions 10 or 20 years, maybe 20 years ago, while we were going and helping those rural areas, now we are really facing with those kind of problems in the large cities. Just think about London, think about Paris, think about Istanbul, think about those countries who are really not very easy at having a very easy access in means of physical access, traffic, and other, maybe economical conditions, and also about the health systems, which are making it difficult to consult our patients to skillful psychiatrists. It's not only DSM-5. It's not only the DSM-5 and such kind of diagnostic criteria, which are created in the hospital base mostly. But we are in the population out of the hospital. I will tell you last thing, which is maybe a few minutes later, a defense thesis of one of my students is about to start. So I will be going there also. What she found is, and it is in the literature, by the way, just the first 5 diagnoses in psychiatry clinic in our hospital, in our training university setting, the first 5 diagnoses makes more than 75% of whole psychiatric diagnosis in a year's time. Just keep it. In ophthalmology, the first 5 makes 97% of whole diagnosis in a year's time. And in family medicine, only 15 to 30% of the cases are in the first 15 diagnoses. So think how we will train our family doctors. It is really complex. It is really complex. But if you train your assistants, residents in ophthalmology, let's say, or in cardiology, immediately for the 5 diagnoses, most frequent 5 diagnoses, you may put them into work immediately because they will be confident that they will make 90%. And the rest 10% will be belonging to the real consultants of that area. But in family medicine, it is not possible. You have to be really very well trained, and you have to be in very good collaboration with the psychiatrists. I'm talking about the subject. You don't need to be a psychiatrist. You can't. It's impossible for you. But you have to be getting some tips from your consultants and colleagues to be used in your very busy practice to exclude the harmful behavior for the person and for the family or for the others. This is important. And to make their life easier, you have to use some simple primary care tools. While if you are suspecting from depression, just to give a depression scale, which should be very short, not a huge one, to be filled in front of you or somewhere there for your patient who is seeking help. I'm not talking about those who doesn't seek help, but who are seeking help. The last thing, the world is migrating. In the Europe, you have very difficult conditions from those migrants, immigrants, and refugees. So that means this is another problem that the psychiatrists should come and work with the primary care physicians in order to touch and to make improvements in the health of the Europe also. Thank you.
Thank you so much, Dr. Ungan. I think you have mentioned a lot of things that actually sparked some reflections in my mind, and I'm sure our participants think the same. Especially how the role of, like, the fact that as family medicine practitioners, as primary care practitioners, you are in the society with the patients. So like Dr. Jenkins said, it's very important that we look at the patient through a biopsychosocial lens. And I think in family medicine, we get this opportunity to especially look at them through the social lens. So it definitely takes more than the DSM, the manual, to actually recognize the struggles our patients are having and to follow up on that. And I think the comments you made about, like, the system, the registries in the UK, and how, like, the family medicine practitioners get to actually follow up on patients sometimes for a lifetime, gives a greater advantage in recognizing their comorbidities and improving their quality of life. And I think this also raises the question, what's the role of family medicine physicians in different healthcare systems, and how this role, how the system is built impacts the quality of the care that they're delivering. We actually have some comments in the chat, which is sort of like in line with what we have just discussed. And I kind of want to go through them before we move on to other speakers, if that's, like, cool for everyone. So from Filiz Ak, she has shared an experience. So she says, about 2 years ago, the Provincial Health Directorate in Ankara, which is the capital of Turkey, gave in-service trainings on anxiety and depression to all physicians working in primary care. Family residency programs also have been giving the skills for primary care follow-ups of depression and anxiety. But nearly for 5 or 6 years, there are serious problems leading to exclusion of primary care physicians from psychiatric follow-ups. The reason of the problem is government and budget execution instructions. Primary care physicians can't prescribe drugs, only psychiatrists can prescribe. As a family physician, I have been following many patients with depression and anxiety. It is my special interest, but for 5 years, I cannot prescribe drugs. I need to send my patients to psychiatrists for prescriptions, and psychiatrists are not glad because of this workload. So we're actually seeing a contradiction to the ideal things that we have discussed in the early of our discussions. Dr. Jenkins, would you like to add something?
Thank you. It was just to flag that this can be a common problem in some countries, that the family physicians or the primary care nurses may not be allowed to prescribe. And so often there are things you have to do at government level to sort the problem out, to anticipate it and sort it out. Sometimes it isn't a legal problem. Sometimes it's an attitudinal problem in the pharmacies, that they won't distribute the medicines to primary care and they just sit at the district level. So the hold-up can be at several points, but as Professor Sartorius was saying, in every country, you have to appraise the system and see what the situation is before you try and sort things out. Yeah. Thank you.
I agree, yeah.
Thank you, Dr. Jenkins. Dr. Ungan, would you like to add anything on top of that?
No, this is very correct what Sarah is saying. You know, this is all about the resources of the country. Can you believe that in Europe we have facing with many different details in the systems? So it's all about how you accept your discipline. So the family medicine and general practice discipline rules are unique. So whatever the system, we have to learn them. We have to try to apply them. I was talking with a colleague in Tanzania right now, and he is practicing in the same way which I have been practicing in Istanbul or in Ankara or in London. The principles of the family medicine is same, but the systems, and it should be over the policy level, which is really belonging to the associations and the, like Wonka Europe, like, you know, the huge associations which should be interacting with the WHO and WHO with the governments about the prescription rights. For example, European Medicines Agency should really fight for the prescription rights for the nurses and for the doctors. So it should be for each country.
Yeah. So basically, I'm going to give the word to Dr. Sartorius in a second, and then Dr. Devat. But just to sort of like recap on that. So the practice of general practice or family medicine, it is very universal. However, like the discipline is very universal. However, because of the healthcare context, because that this can differ from a lot of from country to country, the actual practice and the way that we integrate psychiatry into primary care can differ also greatly. Dr. Sartorius?
Yeah, I just wanted to remind ourselves that the relationship between general practitioners and psychiatrists is not always cordial. In fact, very often it's avoided actively. And it is at different levels. On the top level, for example, the general practitioners have decided that they do not want to have a classification like the other doctors. They want to have a separate one, which they call ICPIC, which is a very nice piece of work, very useful for them, but in no way reflected in the classification that is used by the specialists or by other branches of medicine. So it's just an illustration that one of the targets and very important tasks for us is to think of ways in which psychiatrists and general practitioners can get to know each other, to see that both of them are in fact quite reasonable people and that they can collaborate, which is not at present the case. We have in some places, I've seen, for example, that the teaching of how to deal with a person who has anxiety has been done not in the Department of Psychiatry, but in the office of the general practitioners with him present, so that both of them, in both the patients got his interview, etc., and participated in this in a manner that so that the psychiatrist is not a beast that works somewhere in a curious place far away, but it's just also human, and that a relationship can be established. And I think that that's something we shouldn't forget. It's not only the problems, it is also that we should seek personal communication between specialists and general practitioners. Perhaps different in different countries, but certainly important in all.
Yeah.
Thank you, Dr. Sartorius. Can I give the word to Dr. Deva? He had his hands out.
Yeah.
And then Dr. Jenkins
very briefly,
again.
very briefly, two things. Yeah. The first one is to address the issue of training. I think from what Dr. Ungan has said earlier, I think in Istanbul, they actually did some kind of training to detect anxiety, depression, and so on. But because of different reasons, this is sort of watered down now and may not be occurring. That's very much the case in many places. I started similar training way back about 35 years ago for GPs. One-off thing, not official, through the GP college. And they were very receptive of it, but after that it died out. What it really means is we do not have a primary care psychiatric component in the training of GPs. GPs are taught many things: how to do a pap smear, how to do X-ray, and how to read an X-ray, and so on, so on, so on. I agree with Dr. Ungan earlier. Enormous amounts of responsibility put on GPs. GPs are the most extensive specialty of all medical disciplines. What we're doing in psychiatry or surgery or neurosurgery is nothing compared to what the GP. The GP has got to be a jack of all trades and a master of all. Not possible. So what happens is we got to water down psychiatry and gynecology and pediatrics and cancer to the level of a GP. That, unfortunately, has not occurred in many, many, many countries, including my own university. The GPs are caught in a sort of identity crisis. Some of them want to go excessively into cardiology. Some want to go into something else. So for psychiatry, my suggestion is, because psychiatry, easily takes up 25 to 30%, I'll show you in my presentation later, in the primary care workload. I think we should ensure that at least a few weeks of primary care psychiatry is taught to all GPs in training, not being attached to a psychiatric ward. For heaven's sake, no. The second thing is about this prescription problem. Every developing country has this problem. Fortunately, I worked in a number of developing countries that have developed very good models on the prescription issue. They have very few psychiatrists. I'll give you one example, Cambodia, which has now got about 50 or 60 psychiatrists. When I first went there to work, there were 10. And the 10 had just been produced after the Pol Pot regime and the Civil War. The 10 people for even 6 million is ridiculous. No way you can provide service. So what they did was they came to a conclusion, hold it. We have a lot of nurses. We'll train the nurses to deal with only a limited 4 or 5 types of drugs used in psychiatry. And the dosage. They cannot increase the dose. They cannot decrease the dose. They can continue the dose. Under certain circumstances, they can ask permission from the nearest psychiatrist by a handphone and increase the dose according to what he has said. So that you can put in regulations to control the medication. In fact, that's being done in America. Believe it or not. In America, there are nurses, psychologists who are allowed to prescribe, but with restrictions, not like the psychiatrists. In Malaysia, we had the same problem. We have a huge part of the country which is now better developed, but in those days, it was very poorly developed. The whole state with 50,000 square miles had only one psychiatrist. He couldn't cover everything. So the nurses actually were given the authority to use certain types of medication, limited to about 4 or 5 different medications. They can continue the treatment. They can reduce the dose. They can stop it. They cannot increase it without a phone call to the psychiatrist. So you can put these things. Even in Europe, I think with all the communications that you have, that can be done. That's my suggestion. Of course, I fully agree with Professor Sartorius that every country is different. I agree with Professor Jenkins, every country is different. What I will talk about is about my country. Thank you very much.
Thank you, Dr. Deva. Dr. Jenkins, would you still like to add something?
Sorry. It was to pick up on this point about the links between primary care and psychiatry, if you like, which I think is very important, and to say a few things. And it's obviously poses different challenges in different countries, partly depending on what the proportion of psychiatrists is that you've got, or often it's psychiatric nurses. We may be talking about psychiatrists, but the next layer up, it may often just be a psychiatric nurse. And so the ratios will be different from place to place. The logistics, the geography and the transport difficulties will vary from place to place and country to country as well. So one has to grapple with those. But nonetheless, I would say it is a really important thing to achieve. And I'm sorry about keep using Africa as an example, but anyway, in Kenya, when we did quite a lot of training of primary care, We also put the district psychiatric nurses and the regional psychiatrists through the same training, partly, not because they didn't know the stuff, but so they would then be very familiar with what the primary care staff had been taught and would have be able to think through the opportunities they might have to support those primary care teams. So afterwards, we followed up a number of the district psychiatric nurses, and they were variable, as you might expect. But there was one brilliant woman who made sure that she visited every primary care clinic in her district at least once a month to spend a session with them. And she would sit with them to see difficult cases. If they had to refer somebody to the outpatient clinic, she would see the patient with the member of staff referring. And her district medical officer said to me, since she has been doing this, he said, the district is calm. We have no more suicides. We have no more violent psychotic people rattling around the surgical ward, making a nuisance of themselves. We have no more naked men in the marketplace. He said, everything is sorted, because primary care is doing its stuff, and she was giving them a lot of support. And what she'd done was go to her district medical officer and ask for the use of the Land Rover so that she could go round to every primary care clinic and do this for them, as well as handle her own outpatient clinics and her own small number of inpatient beds. So she was devoted, and she did it in a very systematic way. But I think it shows that it can make a huge impact. The other thing I would like to just say, if I might, is an issue about supervision, formal supervision. What I found is that the district supervisors, whoever they might be, and often they're the district public health nurses who go out to supervise primary care, they supervise in whatever is in the health strategy at the primary care level. And it's usually maternal health, child health, and malaria, say, maybe HIV. And so even if you might train them and they say, yes, they want to support and supervise about primary care, they don't unless it's in the strategy, because they supervise on whatever they have to collect data on. So often if you look at the strategy, mental health may be at the top national level, but it's not mentioned when you get down to the primary care level. And it needs to be mentioned there with some kind of target so that the supervisors will come and have that dialogue with primary care. Sorry, that's all I wanted to say.
Thank you so much. I think the last point you made is very interesting. It's like change does happen in the grassroots local level, but also it's very important that it's supported in the national and subnational and local policy with clear targets, so people can so the change and the accountability with it comes in a more sustainable fashion. So thank you so much for that. I think that was very interesting. Dr. Sartorius, would you like to add something? And then Ramin will take over. Yes.
Thank you. Just to continue with Professor Deva and Jenkins, by an example from Switzerland. In Switzerland, some years ago, quite a few years ago, they decided they would help general practitioners to learn a little more about psychiatry. And they've organized courses where psychiatrists have been giving courses, and nobody came. That is, people were coming, but they were bored. They came once and never came again. And it was quite a failure. And then they decided they would change the training altogether. And they did it, and it had three features, which I think were very unusual. The first feature was all the training was done by general practitioners who had some experience and who were telling their own experience to other general practitioners. This is how I dealt with the problem of anxiety. A psychiatrist was present as a resource person who could be invited to make a comment when necessary. But basically, it was two, in fact, they started later, there were several. The general practitioner was speaking from his own experience. He is also a credible person for other general practitioners because they feel that he faces the same problem and works in the same situation. So he was much more credible. They listened to him with much more interest, and they learned a great deal about cases which are seen very frequently in general practice. So that is one feature of it. And then they did something else which was unusual. Then they put a price on that, an entry ticket. in the first instance, the first part, they were paying for people to attend. But now that they have established this round system, they ask people to pay to be allowed to enter the training. And they could not accommodate the numbers of people who wanted to come. They liked what was being done, and the value that was given, it was obviously something interesting. So I think in a short while, practically all of the general practitioners who were in the district of Basel and Basel-Stadt, several cantons, have been trained in this way by having general practitioners educate with the help of a psychiatrist, focusing on a particular thing and making the whole thing as a gain for the GP, not as an obligation, which was cumbersome and time-consuming.
Thank you, Dr. Sartorius. Dr. Ungan has written yes.
Yeah, just this is just the note that, you know, it's very good to see that the peers are the peer training is always much better than the other kind of relation with the teacher. So in general practice, it's very valid. Thank you, Dr. Sartorius. This is a very good sample for Switzerland.
And I agree. And in Kenya, our trainers were former primary care staff. I mean, they were the college lecturers who rolled out the training across the country, but their background was from primary care.
Thank you, Dr. Jenkins and Dr. Ungan. We do have one more question in the chat, but I also see two hands up from Dr. Hatipoğlu and Dr. Coşkun. Dr. Coşkun, would you mind if I gave the word to Dr. Hatipoğlu first, or would you like to say something real quick? Dr. Hatipoğlu?
Hello to everybody. I'm in Izmir, but I want to say I wrote on my chat, but I want to say that the Ministry of Health is doing some educations since 2016 with the cooperation of WHO for the raising mental health of the population for the primary care doctors, and also they are planning to do this for the nurses also. And I think we have almost done 100 educations like this, and afterwards we are preparing the doctors or primary care workers from the primary care workers, and the peers are from the psychiatric clinics, and we were planning to do this in the cities, but the pandemic has blocked our training, and I think afterwards we will do these trainings in the cities also. And I'm one of the trainers, and then I'm also a member of the Izmir branch. And I think this also helped a lot for us. But yes, we can't write some prescriptions, we can't do this, but we say we are writing those medicines you can buy yourself, or you can go to psychiatry. Yes, the psychiatrists say we shouldn't write. You have the opportunity, but it's like Mr. Ungan said, it's a sort of the government's choice. But I think afterwards, it's getting better for us, for the primary care, to deal with the population. Thank you.
Thank you, Dr. Hatipoğlu. Dr. Coşkun, would you like to add anything?
That's why I raised my hand. Well, first of all, I'm very pleased that there are so many participants in this meeting, in this fourth intergenerational meeting of ours. There are a few questions in my mind. Are there any medical students other than you two, Ramin and Idil, among us? That's a question in my mind. If there are, would it be possible for them also to take the floor? And another thing is, when I was working at Kocaeli University, we had an experience with GPs. The name was Learning Together. We were having some meetings together with our GPs at their health centers and sometimes at the university. When they were with us at the university, they took part in the training of the clerkship students as sharing their experiences in the field. So I wanted to share this experience as well. Thanks. Maybe Ramin could continue if you don't mind, Idil.
Absolutely, yeah, of course. I was actually going to hand it over to him because I kind of feel like I did my fair share of talking. Thank you so much, Dr. Coşkun, for sharing your experiences. Ramin?
Yeah, thank you very much. Yeah, I think this intergenerational meeting has had a lot of fruitful discussions. And I just like to share a little bit more. I think in our previous, before I go into that, at the end of the question, the earlier chat that we were talking about, it was stated that, the primary care physicians were not allowed to prescribe psychiatric medications. And I think one important point I would like to raise is that oftentimes we forget that psychiatric conditions can also be treated with, the non-pharmacological methods that, we have learned as well in our med schools. So I think this point was raised by Dr. Nicholas during our previous intergenerational meeting. He has actually practiced something here in Malaysia, but it's not something I have experienced. So I'm just quoting some of the things he said. For more details, please go and watch that intergenerational meeting. But yeah, roughly it goes along the lines that they've begun to introduce psychological interventions to their medical students, and they've even incorporated it into their final exams. And what this has accomplished is that it allows the medical students, when they graduate and when they pursue, whatever field that they may pursue, if they are able to detect someone with a psychiatric condition, they're able to perform some baseline, some general basic psychological interventions, and try to handle those situations on their own first before referring it to a psychiatrist. And they would only refer it to a psychiatrist if the initial psychological interventions were not really useful for that particular patient. So in that way, it's sort of allowed psychiatrists to have more time for more severe patients, and it also it was seen to have a huge success rate in his university, I would say. But yeah, I think he has worded it much better than me. I'm just paraphrasing anyway. Moving on to another question from the chat, from Hakan Demirci. I'm so sorry if I'm mispronouncing it. What do you think about the usage of questionnaires by family physicians, such as Beck's depression inventory, while diagnosing or during follow-ups? So perhaps we can go to some students if they're available, or we can have the senior members to have some comments first.
Yeah,
maybe Dr. Dr. Ungat, go ahead.
Yeah, just it's not. I mean, just I would really like to hear Dr. Joshkun, and also because you know, he's very familiar with the general practitioners. So he might recommend us some kind of short questionnaires which are very useful sometimes for me. For example, those short scales like GAD-7 or PHQ-9, which we frequently use in our practices just to exclude some kind of, you know, diseases, which mental conditions actually, or post-traumatic stress disorder for 4 questions. But all of them are very short. But I don't know whether you will be recommending us, Dr. Joshkun, to use those small questionnaires in a very busy practice.
Since you have directly asked me, I'll say just a few words, but try to pass it over to our other senior educators. Yes, of course, I believe they can be used, and they are used actually to detect and also to follow up the process, I think. But I wonder what, I think Dr. Diva has written an answer in the chat, and also we have Dr. Sartorius and Dr. Jenkins. Let me again try to keep silent.
I think Professor Jenkins had something to say as well.
I think I agree with Professor Deva, really. I think these instruments can be very useful if people have had no training in the mental health symptomatology. But I think in a busy clinic where you really only have a few minutes, it's good to have the primary care doctor or nurse able just to use some very simple questions and to be able to handle the answers. You know, are you feeling low? Are you anxious? How are you sleeping? How are you in yourself? Those questions will elicit a lot of information. And then if they're familiar with the common symptoms of poor concentration, fatigue, irritability, etc., they can carry on. So I think my stance would be these questionnaires aren't necessary as long as people have had a reasonably good basic training, and that otherwise the questionnaires might interrupt the smooth flow of the clinic. But Professor Ungan obviously had other experience of this, so I'd be interested in his views. The other thing that I just wanted to pick up from the previous conversation was this issue about some core psychosocial skills, which I agree. And I think there's a layer of them before you get to so-called psychological skills where we're thinking CBT and so on. There's a layer of basic psychosocial communication, support, breaking bad news, supporting the carers, Professor Sartorius was talking about, and so on. There's a range of very basic skills we need to teach before you get to the more formal psychological skills.
Dr. Sartorius, I think.
Professor, you're muted.
The question which one has to ask is, do we have similar questionnaires for diabetes and for heart failure and for gastritis and for, or why do we have it for psychiatry and not for these other diseases? What's so wrong about doing a diagnosis of all diseases that the doctor sees? Some we will do with questionnaires and others we will do in human contact. And I want to tell you a story which is about a book that has just come out. It's a book that came in New York. They published it, and it's called The Rabbit Effect. And why is it called The Rabbit Effect? Well, there was a laboratory in which they were having a large number of rabbits to whom they were giving a very fatty diet, very fatty and very unhealthy diet. And what they wanted to find out is how quickly these rabbits will develop heart failure and die because of their heart failure. And they discovered that when they give this diet, all of the rabbits die, but a small group of rabbits did not die. And they seem to be doing better than all the other rabbits. And they looked whether there's a genetic difference. No, they were the same rabbits. And then they looked whether it's maybe something else, that the diet was not given to them. No, they got the same diet. Yet they were surviving much longer than any other rabbit. And then they went and looked, and they discovered that there were several lab assistants who were looking after these rabbits. And they discovered that one of the lab assistants liked rabbits and spoke to them, and occasionally opened the cage and looked at them. And sometimes she would stroke a rabbit. And lo and behold, these rabbits survived. I mean, all of the other rabbits died. They did not die for a long time. And I think that the message that is in there is a huge number of interventions, medical interventions, that depend on our way in which we are dealing with people. The notion that somebody has to ask a questionnaire to find out whether a person feeling bad is terrible. The first question is about a patient when he comes through the door. What can I do for you? What is it that disturbs you? Is there any way? Do you feel low? This is a human contact which will give you information that is terribly important for later on. Some of these what has been called the non-specific aspects of treatment and described in great detail by Frankl and others is terribly important. And the recent study that has been done has shown that the effects of psychotropic medications, but the same is true for others as well, can be roughly put into three packages. 1/3 of the effect of drugs and medication is due to the drug itself. 1/3 is due to placebo. And 1/3 is due to the non-specific aspects of treatment. How did you provide these medications? Did you, in fact, try to look at other aspects of the patient's life to make these easier, etc.? A whole range. Did you respect the patient? Did you ask him to speak and did not interrupt him? We had done one study in which we looked to see how long it will take before the doctor interrupts the patient. And we found it's 20 seconds. The doctor comes in and says, the patient sits down and says, so he says, tell me about your disease. 20 seconds later that he's interrupted. Say, yeah, but tell me. And he guides the interview. 20 seconds? Give the man a minute. And we have done a small study, which is not to be published because it's very small, in which we have simply asked the doctors, the general practitioners, we've asked them to please be silent for 3 minutes. Just say nothing except for or sounds of that kind. And then we asked the patients, how did they feel about this session? And they told us, we've never been given so good advice as today. It was fabulous. And it was 3 minutes of silence. Very difficult for a doctor. A doctor wants to ask something right away. Never let this poor bastard say anything more than a word. So I think that this aspect of the normal medical interview in which you show that you believe what the person tells you, that you are willing to listen, that you are willing to help. These are things which are terribly important for all diseases and also allow you very quickly to discover whether there is more misery than should be present in a person for which misery you can help him in one way or another.
Yeah, I think that's a very apt point, Professor Sartorius. We have to practice some active listening and some patience when we're dealing with our patients. In fact, I had a phrase of my own the moment I entered my clinical years. I called it, I said, we have, as doctors, we have to have patience. No, we have to have the passion to treat our patients with patience. So it's a kind of tongue twister. But anyway, I think we have a couple of hands raised. Dr. Gokdemir, would you like to share your thoughts? You've raised your hand for a while.
Well, thank you very much. I was waiting, but it was so good for me for waiting and listening when in patience, because I do hope that for the last minutes, I just learned much more for my questions, answer some of them at least. Thank you very much, Dr. Sartorius, to be about patient. And also this reminds us that 5 minutes is not enough for a clinical assessment of a patient. The Turkish colleagues will remember that 5 minutes is not enough of what I mean. And so we will now need more minutes, at least 3 minutes for to be silent. And thank you for reminding us these minutes. And the other point is the thing that I was just trying to ask. In Astana Declaration, we are talking about health for all. In health for all, also the mental health for health workers is crucial. And in Turkey, in 1 week, it was just 3 years ago, as I remember, a medical student, a practitioner who just graduated from the 6 years, and also a surgeon just attempt suicide, and it is terrible that they are dead now. And so we can just say that for all the stages of medical education, we can just face the suicides, and we should save lives. I think it is very important, and we should do something about that. For being patients for 3 minutes, yes, it's important for our patients, but what about us? Can we use these tools to save our lives and to save our mental health as healthcare workers? What do you think about it? That's my question. And also, thank you very much for giving a word to our medical students. So they will have lots of insights and tell us the other things. And thank you, Idil.
Professor Diva?
Yeah, just very
briefly.
briefly.
To take the floor?
Yeah, thank you very much. I just want to very briefly support what Professor Sartorius has said. Way back in 1980s, I started using video to record interview skills among students. Those days, video was already available, but nobody was using it. I learned it in Edinburgh when I was trained. And I came back and I used a stopwatch to find out how long it takes a medical student to intervene after the patient said his first word. I said, what's wrong with you? Well, doctor, I've got this headache. How long have you had the headache? I actually timed it, and I broke your record of 20 seconds. The average was 8 seconds. 8 seconds. Batch after batch, average was 8 seconds. It shows the terrible anxiety disorder all medical students and doctors suffer from. Thank you very much.
Professor Diva, I understand. Oh, sorry. Professor Jenkins, would you like to chip in something?
Yeah, well, it was just briefly that we sort of had a saying in the UK when we were trying to teach UK GPs, with a GP, I may say, by Andre Tiley. And he always used to say that GPs can't really address depression and anxiety in their patients till they've addressed it in themselves. You know, it's very difficult for them to hear about other people's misery while they're suffering with a lot of their own. So they have to have some kind of insight and understanding to sort themselves out before they can be really good at listening and supporting other people.
All right, Professor Diva.
And I would say, because of course it's a high stress occupation being a doctor, so it's to be expected.
Medicine is a wonderful job if you like it. And if you don't like it, you should not do it. There is it's love it or leave it. I think it's terribly important because there are so many frustrations and difficulties that will arrive. You must like what you're doing sufficiently to survive and to invest yourself into it. It's not easy. And I think for many a person, it would be better if they in fact escaped from that job and did something else. Maybe they can go into an office and work into an office or something like this. But to do medicine, provided that you like it, is a tremendously rewarding profession. But it's not for everybody to do it. And I think that it's not a sign of failure. It just means that you are made in one way and not in another way. And sometimes somebody was telling me, it's perhaps better to say I've lost 3 years or 5 years of training, but I live a life which is good, than to have 40 years of work and then say after 45 years when you enter into pension, it really was a wasted life. I didn't like a moment of my life in this profession. I didn't like it. I shouldn't have done it. And I never decided to go out. There are many ways out of the actual practice if you don't like practice. Research is one, for example. Writing is another one. There are many things, but one should be aware of one's own position in relation to psychiatry, in relation to medicine, relation to general practice, relation to being a doctor. And we should not just blindly turn on because it was we were lucky enough to be accepted to a medical school. And now we think that since this luck was with us, we now have to continue for 6 years learning something we dislike and then do 45 years of job that we don't like. So I think that it's terribly important to be conscious of our relation to this profession, because it's a profession that requires intensive and permanent personal and emotional investment. And that's not everybody wants to do this. They're not worse people because of that. They're just not very happy in that particular job. So I think that's something that we should also keep in mind. And then within medicine, there are also wonderful jobs for people who don't like people. Like, for example, radiology. Now you look at the pictures and you don't have to see anybody. A nurse brings you a coffee every hour or so, and you look at this thing and you say, broken leg, or he doesn't seem to have a head, or whichever else he might be saying. That's a wonderful job. It's within medicine, but it's not with people. With people, it requires a lot of heart. And maybe not everybody wants to give it in that, has other business to do.
Yeah, this is nice. Very good comment. What I have had, there is a very good study, a recent study in Europe by a Bulgarian general practitioner, and who proved that the internal locus of control, if it is, I mean, if you have a higher internal locus of control, you have less burnout. And also, I think this is very interesting that the person-centered care is really helping a lot for the general practitioners if you really apply the person-centered care. But also, I mean, we have to decide in our professions, like every specialist or every doctor or every health worker, if we don't enjoy anymore, and that is something that we should be careful and seeking help, and then to decide maybe whether to stop or to continue, because otherwise we may be more than helpful, we may be harmful also to our patients. So this is a very critical thing to know and to be really knowing it. And I agree, it's not like that, you know, if you are not able to escape, try to enjoy. There is a word, you know, in Turkish, we use very, very much for like a jargon, but I think it's not correct. You know, if you are not able to escape, try to enjoy is not the motto of this. So I would just try to emphasize the conditions. The conditions are very important where you are practicing. Although you can change the conditions, it will require a lot of, you know, effort and a good collaboration with the other health workers and the governors. So if you are in a country like, you know, a lot of doctors are being killed, or if your salaries goes down 1%, I mean, 1/10 in the last 10 years, or if you have disrespect in the population too much and increasing, then it affects the young doctors who are entering to the profession in a very wrong way. Although those you know, elderly doctors who are trying to help them a lot and saying that you have to be this way, acting this way, or you have to feel it in this way, you have to enjoy the profession. Of course, the young generation, maybe the psychiatrists know it much better. The young generation are more realistic to see the realities maybe a little bit different than we perceive. And they make their own choices and leaving the country, and then we are losing our resources as medical organizations in the country. So what I would say is, we have to be focusing on managing a patient. It is described in the profession of general practice. Manage the patient. Use the resources also. Using resources and managing the patient is the main responsibilities of the general practitioner in the field. Using resources, we have to be open. Prescription rights, referral system, consultations, feedbacks, and also social services. And also, the hospital and the social, the population services in health. They are all resources that we should be using and also collaborating with the other professions. Otherwise, we will not be able to handle any kind of non-communicable disease for sure.
All right, so we are at the close. We are towards the end of our intergenerational meeting for today. But before we end, we'd like to share a piece of music from one of our medical students. It's an instrumental piece that he has played. Unfortunately, he could not be, he was not able to join us today. But he has shared his music. Let me just bring it up. Right. So this is his cover of Michael Ortega's "It's Hard to Say Goodbye." So that was, yeah, Michael Ortega's It's Hard to Say Goodbye. That was a cover by our medical student, Farhad. He states that this was the first song that he learned to play on the piano. And when he had learned this, it was a time that he was going through a rough time, basically. And he had found hope in music and through playing the piano. So yeah, with that, I think we can, before we bring our meeting to a close, I think we can have some closing remarks from Professor Coşkun.
Thank you, Ramin. Farhad Hüseyinov was the playing colleague. He is from Azerbaijan and studying medicine in Uludağ University in Turkey. Ramin gave information about him. I would like to thank all of you who have participated in this meeting. And thanks a lot. Please share your reflections through mail or through any other communication channel you can. Hope to see you in our next intergenerational meeting as well. It will be on fear of psychiatry. Thanks to all for being with us.
Thank you.